So papillary muscle therapy, what could I be talking about here? Well, so here are my disclosures. I do have disclosures despite that previous slide. So this was not my patient. It was one of my partners. He's an 85-year-old man, but I got involved with this patient. You'll see how. So he was 85 years old, and this was about a year ago. Severe aortic stenosis, had porcelain aorta, and he had no access anywhere. And so, we look at the carotids, we look at various things. We weren't doing transcaval at that time, but at the very least, in the periphery, the only option for him to get TAVR was a transapical approach. So he comes to the hybrid room, and he gets TAVR. Richard, were you doing this case? I can't remember. It may have been you or Des, but he gets TAVR. So on the left-hand side, there's TE because it's transapical, general anesthesia. And you can see there's the TAVR before and the TAVR after. So anybody know what happened? So, all right, well, we'll keep going here. So obviously, there's a lot more MR after the valve has been put in, and this is what happened. So when your echocardiologist asks you what the ACT level is, it's never a good question, right? You never, because if they're asking you why, or they see something flapping around, it's never good. So obviously, there's a papillary muscle that's been torn and ruptured, and it must have happened either during the sheath placement or during the valve advancement. At some point, the papillary muscle got torn. So at this point, I was called to ask and give an opinion. Any thoughts on how to fix this? He can't have surgery. He's got a porcelain aorta. He's inoperable. We probably would get sued if he opened his chest. I think, Jonathan, you might have been there, so you can't say anything. Neocord or clip? Yeah, so we didn't have neocord, so it was clip. So they asked me, could I clip and take care of this papillary muscle? So I said, well, we'll give it a shot. So here's a transeptal, and you can see the height here. This was with the standard NT. Height was 4, and then we brought the clip here in the top right-hand side, and it actually took no more than 10 minutes. It was actually really easy to get down, get underneath the valves. You can see there on the lower left-hand side, the clip, the leaflets fell right in. And at this point, my thinking was, well, where do I want the papillary muscle to end up? Because, this is ruptured. It's flailing into the left atrium, flopping back and forth between left atrium and left ventricle. And I'm thinking to myself, well, nature wanted the papillary muscles in the LV. So we kind of timed it to where you can see in the bottom right-hand side, if you look very closely, I don't know if my mouse plays here, yep, you can see the papillary muscle is trapped on the LV side. And so I think we got what we wanted, and it looks like it's better. The mitral valve is secure. And here's the MR. MR is fantastic. I mean, my surgeon was ecstatic. I don't have to open this patient. He's going to do okay. So any thoughts at this point as to what could be wrong or what could happen? I'll give you a clue. It's acute MR.
Prolapse of the muscle.
Huh?
Prolapse of the muscle.
Prolapse of the muscle, yeah, I think it's trapped though on the LV side. No, LV was okay, but you're right. You're relieving acute MR. So this is what was found. Gradient is 19. So the valve is small because this patient had no mitral pathology to begin with. And so the valve was small from the get-go. And we put a clip on. Remember, the clip will generally drop the valve area by about a half. And this one, I think it probably almost entirely closed the mitral valve. So now the arms are closed, the MR is gone, but he's got unlivable, non-survivable mitral stenosis. So thoughts at this point?
What was the gradient before you released?
It was in the 2 to 3 range. Oh, before I released?
Yeah.
I haven't released yet.
Good. Very good.
No, so the clip is still, it's closed, it's still on the sleeve, and the decision is, well, now what do we do? Because if I let this go, MR is going to come back, he's going to go into shock, and probably not survive.
I don't think I've ever created.
Pull out the tendine? Well, we don't have emergency CT, but you're right. A retrievable, repositionable valve in multiple sizes would actually be quite nice, and maybe off the shelf Tendyne in the future would be appropriate.
So, Paul, you did this case acutely at the immediately post TAVR.
Yeah.
The
Mhm.
patient was sick and all that stuff.
That's right. So the chest is still open, TA is still open. Yeah. Yeah, so I thought about that. I thought about letting the papillary muscle fly up. Maybe that's contributing to stenosis. So what I ended up doing is I simply just opened the arms up to about 60. And so that got the gradient down to around 7. So this is a trick you can do with mitral clip. You can open it up, sorry, not 60, 30 degrees or 60 degrees, depending on which way you view it. Around 30 degrees, that got the gradient down to something more acceptable, is around 7, and the MR, while it's not completely gone, it's probably more survivable. And I'll tell you, the next day the gradient on the transthoracic was higher, it was in the 10 range, but you know what, it was the best that we can do, and we medically managed him, and I think he did okay. I can't remember what he did down the line, but this is the best that we can do. So anyway, I think there are some interesting teaching points here. The way I see this case is that this was a bridge to get him out of the hospital and survive his procedural event, because he would not have been able to survive it otherwise with that papillary muscle rupture and him needing to have his AS treated. So you can repair papillary muscles. I've seen this not with just iatrogenic injury like this. I've also seen a case that was sent to me with post-infarct papillary muscle ruptures. That patient, actually almost similar scenario, caused some stenosis, but was survivable. I think about trapping the papillary muscle in the LV just because I think that's how nature intended it. But one thing for these, if you're thinking about doing this, beware the small size of the mitral valve, because these are acute ruptures, and you're going to be acutely reducing a normal-sized valve in terms of the area. So thank you very much.
Don't run away. No, I was just wondering, because other people might say, okay, this is an option. So from a device aspect, what angle can you leave it and it's safe to close? I mean, there must
30.
be something in the, is 30?
30.
Okay.
Well,
What, not more than 30?
I don't think the IFU says 30,
Yeah.
but it's commonly known.
That's 30.
Mitral clip, you can leave it at 30.
But not more than that.
Yeah, not more than that.
Yeah.
And whether that holds true for XTR, I don't know, because you're given an extra couple of rows of gripper with XTR. I don't know if that's true, but at least with the normal size clip, it's 30.
I think this is one of it's a really important case for a lot of different reasons. But we had a case of a patient with acute MR due to pap muscle rupture as well. And the patient we did the same thing, and they did great, except for within 2-3 weeks, just the medical management, all these other things just became a horrible setup with dialysis and so on. The other things that we can think about in the future for something like this, I mean, Pascal would be an interesting option because of the spacer for that stuff. And then other things, I think with the Apex Open, was there any other option for thinking about even just doing a chordal setup? What other things could you think of in
So the
this
surgeon didn't
case?
feel that they could get to the pap muscles and do whatever they could to repair it. Yeah, they would have had to go on bypass, and there was nowhere that they felt that they could safely cross-clamp the aorta and put it and do cardioplegia to open up. I don't know, Michael? Yeah. Yeah.
Right.
Yeah. Yeah.
Mike Tracy did all his mitral valves under ambulatory arrest.
Sure.
I mean, you know, as a surgeon, if you're not anxious to go in like the last case, when they're in good shape, you should be a little less anxious to go in when they're in bad
Yeah.
shape.
Right.
So, you know, but again, if you have to save somebody's life, you have to save somebody's life.
Yeah, and the other thing too is, you know, if you deem a patient inoperable, you have to be really wary about what you're willing to offer in terms of surgery. You know, I know of at least one case in which a family sued the physician because they operated on the patient when they determined the reason for TAVR was that they were inoperable. So you gotta be very careful. And so if they're inoperable, they're inoperable. And so,
Reflect, Paul,
yeah.
about how we got the pathway muscles, because they're all posterior, so it's hard to get it with your sheath. You must have, I mean, do you have any thoughts about what?
I wasn't there. Yeah, I wasn't there. I suspect it may have been the wire probably got entangled somehow, and when the sheath and the valve went in, it tore. Yeah, it wasn't during the BAV because they had done the BAV before. It was after they put the valve in, so it was probably with the big sheath.